And now we'll return to the brachial plexus. As you might note, a lot of this will be a repeat of what we discussed on the previous page, and this will serve to hammer in these relatively distinct clinical entities. The circle numbers correspond to the injury in the legend on the left. Number 1 is a waiter's tip, which is an injury of the upper trunk as we discussed before. 2 is the total claw hand, or Klumpke's palsy, caused by injury to the lower trunk. Number 3 is a wrist drop, which occurs with an injury to the posterior cord, though notably there are other injuries that could cause this presentation as well. Namely, the 6th labeled nerve injury, or a radial nerve injury, could cause wrist drop. This makes sense as the posterior cord itself gives off the radial nerve. The 4th injury is a very important one to remember. That's a long thoracic nerve injury, which causes a winged or prominent scapula. We'll discuss this in greater detail in a second. The 5th labeled nerve is the axillary nerve. The main muscle the axillary nerve innervates is the deltoid, so an axillary nerve injury leads to deltoid paralysis. The nerve labeled 7 is the musculocutaneous nerve. We haven't discussed it before, but it's the nerve that innervates the flexors of the elbow, namely the biceps brachii. Since it's the musculocutaneous nerve, it's also responsible for some cutaneous innervation. Injury to the musculocutaneous nerve, therefore, is pretty intuitive, as it causes difficulty flexing the elbow and variable sensory loss depending on the site of the lesion. The next lesion is the distal median nerve injury we discussed before, with decreased thumb motion. This is referred to as ape hand. Remember, more proximal nerve injuries would not present with only this abnormality. The final injury is one to the distal ulnar nerve, which causes difficulty with the intrinsic muscles of the hand. This causes a claw hand and is also called the Pope's blessing. I know that was another whirlwind of information. When you think about how many nerves there are and the fact that people do some crazy things, it's a wonder that the plexus isn't injured more often. One thing that helps is that the clavicle presents many direct injuries. As an added layer of protection, the subclavius muscle also protects the brachial plexus, which is necessary as people often fracture their clavicle. This table is another permutation of similar information we've mostly already discussed. To this point, we've discussed the different nerves, the different areas of injuries, both distal and proximal, and mechanisms of injuries. Before this, we've only grazed over the motor and sensory losses associated with each injury. This table really goes into a lot more depth. We'll skip over reviewing things we've discussed already and focus primarily on motor and sensory deficits associated with each nerve. In some cases, we've basically discussed all of it, for example the musculocutaneous nerve. Also, before we begin, one quick note: the sensory deficits in the rightmost column may appear a bit random. That is, you'd think the sum of the 5 nerves associated with sensory deficits should give you a rough picture of sensation across the entire arm. This doesn't actually play out because many of these 5 nerves actually overlap, so sensory deficits can only really occur if a nerve has a region that primarily innervates by itself. As you'll see, this doesn't happen all that often, until the hand really. For the axillary nerve, this is straightforward and we've discussed most of it already. The motor deficit's the deltoid, which means the presentation will likely be difficulty with what motion? Abducting the arm. The associated sensory deficit is the skin overlying the deltoid. It'll present in clinic with an atrophied or flattened deltoid. The radial nerve is more complicated, as you likely have realized already. There are 4 muscles or muscle groups to associate with the radial nerve, and most of them are extensors, giving rise to its nickname, the great extensor nerve. You can remember this with a memory aid best: brachioradialis, extensors of the wrist and fingers, supinator, and triceps. The associated sensory deficits follow the course of the radial nerve: posterior arm, and dorsal hand and thumb. In the clinic, look for wrist drop. Next we'll look at the median and ulnar nerves. The median and ulnar nerves each have motor and sensory deficits broken down by either proximal or distal lesions, following the pattern we discussed before. Let's start with the median nerve. Proximal median nerve injuries will cause difficulty with flexion of the wrist and lateral fingers. Accordingly, loss of median nerve innervation will lead to a loss of sensation of the lateral 3½ fingers on both sides of the hand, as well as the thenar eminence. More distal lesions will have a fairly different presentation. They usually occur at the median nerve at or more distal to the wrist and present with difficulty opposing the thumb. The sensory loss is identical, except that you keep sensation to the thenar eminence. Look for the ape's hand or Pope's blessing hands. Proximal ulnar lesions also lead to difficulty with wrist flexion, as we saw with the median nerve, but this time it leads to medial flexion difficulty. The sensory loss of proximal ulnar lesions also has similar correlates. It occurs on the medial 1½ fingers and the hypothenar eminence. Distal ulnar lesions are actually quite different. First, there's no sensory loss, and the motor losses are really varied. There's a loss of abduction and adduction of the fingers, loss of adduction of the thumb, and loss of extension of the 4th and 5th fingers. In the clinic, look for radial deviation of the wrist upon flexion. Like I said before, we've already kind of discussed the most important aspects of the musculocutaneous nerve, but as a brief review, injury causes difficulty flexing the elbow and sensory deficits in the lateral forearm. Before we move on to some of the named clinical entities, we want to call out one more important piece of this table. That is to say, the nerve roots that are indicated next to each of the named nerves in the first column. While it's not the most high-yield information, it may be worthwhile for you to create a system for remembering the entire brachial plexus. And now the long-awaited waiter's tip. Now that we've talked about this topic a few times, let's actually learn how these patients present. As a review, this occurs with upper trunk injuries and follows a direct trauma. It can also follow a trauma during a delivery through the birth canal, so keep this in mind for question stems that mention arm palsies immediately after birth. Clinically, patients present as the picture indicates, with a limb hanging by the patient's side, medially rotated, with a pronated forearm. This occurs because of the loss of some of the abductors, namely the C5 and 6 roots, and their contribution to the axillary nerve, as well as the loss of the lateral rotators and biceps, which derive innervation from C5 and 6 roots via the musculocutaneous nerve. As we discussed before, thoracic outlet syndrome occurs as a result of an additional cervical rib that pushes against the C8 and T1 roots. It may also affect the subclavian artery. The constellation of symptoms that you see all derive from the compression of these two structures. First, as with all chronic denervation, the distal muscle groups innervated by this trunk lose their endogenous trophic factors and undergo atrophy. This includes the thenar and the hypothenar eminences, as well as the interosseous muscles. As the C8 and T1 dermatomes are on the medial side of the arm, the compression also leads to sensory deficits of the medial forearm and hand. Finally, and likely the most interesting of all, is that the radial pulse actually disappears when you move your head toward the ipsilateral side of the cervical rib. The syndrome can also result in damage to the lower trunk of the brachial plexus, leading to Klumpke's total claw, which we'll discuss in a second. We have at some point discussed all four of these hands. However, now we'll discuss exactly why they present the way they do. In almost every case, it relates to the lumbricals. These peculiar muscles are responsible for doing three things: flexing the MCP joints and extending both the DIP and PIP joints. MCP stands for metacarpal phalangeal, DIP is distal interphalangeal, and PIP is proximal interphalangeal. The final distortion is called the ulnar claw, and it's pretty straightforward. Loss of the ulnar nerve distally leads to a loss of function in the medial lumbricals and an inability to extend their fingers. When the patient tries to flatten or open their hand, their pinky and ring fingers stay clawed. This creates the so-called Pope's blessing. Another clinical entity can look quite similar, but it's actually a median nerve injury. Here a patient might lose the ability to flex the lateral fingers, so if they try to flex those fingers, they would appear to have a similar Pope's blessing appearance. The next claw is the median claw. Here, a distal median nerve injury leads to a loss of the lateral lumbricals, unlike an ulnar claw which affects the medial lumbricals. Hence, if a patient tries to open their hand, their first two fingers stay clawed, and you see a median claw hand. The third distortion is called the ape hand, wherein a patient suffers from a proximal median nerve lesion. This predominantly affects one nerve and ultimately one muscle, the opponens pollicis, which is responsible for opposing the pollex or the thumb. This leads to an unopposable thumb, much like an ape, thereby making it an ape hand. The final distortion of the hand is the Klumpke's total claw, which we discussed in the context of lower trunk injuries, as well as thoracic outlet syndrome. Here there's a lesion of the lower trunk, wherein patients lose function of their lumbricals. If you imagine lumbricals being responsible for MCP flexion and the DIP-PIP extension, then loss of these means the muscles that do the opposite action are all unopposed. Therefore, the presentation for these patients is a hand with MCP extended and DIP-PIP flexed, or a total claw hand. The next fact is mostly an extension of the information you learned a few pages back. Remember when you sever the long thoracic nerve, the resulting injury is a winged scapula. This is because the serratus anterior is the muscle that is innervated by the long thoracic nerve. The function of this muscle is to oppose the scapula to the posterior thoracic wall. Without it, the scapula protrudes posteriorly, much like a wing would. The classic question you'll see in your boards is a patient who had surgery for breast cancer, often with an axillary dissection for the lymph nodes, who then presents with a winged scapula after surgery with or without lymphedema. This is because the dissection process, or even the mastectomy itself, can sever the long thoracic nerve. The next section is here to highlight some important muscles in the hand. Why? Because the hand is complicated. While it's not incredibly likely you'll see something about this on the boards, it's worth remembering what the muscles are because the case vignette will often offer the motion of the hand that is compromised. If you know the anatomy, you should have most of the answers easily available. There are four sets of muscles you should remember. The first is the muscles you'll find in the thenar eminence. These are the ones that oppose, abduct, and flex the thumb. Specifically, you'll have the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. There are similar muscles accordingly found in the hypothenar eminence of the little finger. The third set of muscles are the interosseous muscles, both the dorsal and palmar sets. The dorsal interosseous muscles abduct the fingers, while the palmar interosseous muscles adduct the fingers. The memory aid dab and pad is a great way to keep these two straight. The final set of muscles is the lumbricals. The action of these muscles is a bit strange, as we've discussed already. They not only flex the MCP, but also extend the PIP and DIP joints. Does anyone remember what hand distortion results from loss of function of all the lumbricals? Exactly, a Klumpke's total claw, often caused by a lesion of the lower trunk. Now we have the lower extremity. This is probably a lower yield section than the upper extremity, but it's still important. There are a few types of injuries you'll be expected to know, and almost all of them are listed on this page. As we work our way through the chart, let's first just look at all the nerves. You've got the obturator, femoral, common perineal, tibial, superior gluteal, and inferior gluteal. One thing to recognize is that while the nerve roots listed create the first pair and last pair of nerves directly off the spinal cord, the common perineal and tibial nerve are actually terminal branches from the sciatic nerve. Now let's work our way down through each of the nerves listed. The obturator nerve innervates the muscles along the medial aspect of the thigh, which are all muscles responsible for adduction of the thigh. It makes sense then that injuries of the obturator nerve will cause difficulty with thigh adduction and sensory loss of the medial thigh. The next nerve listed is femoral. This nerve runs anteriorly in the thigh and subsequently innervates the muscles of the anterior thigh. These primarily include the quadriceps muscles, which are responsible for leg extension, but also include some of the accessory flexors of the hip, namely the sartorius and pectineus muscles. If you lose innervation provided by the femoral nerve, you expect difficulty with thigh flexion, leg extension, and a sensory deficit on the anterior thigh and middle leg. The next two are worth remembering together, in part because they both originate off the sciatic, but also because their motor and sensory attributes are almost entirely mirrored. When you think about the common perineal nerve, also called the common fibular nerve, you should think about the fibula, which lies laterally on the leg. It provides innervation to the muscles of the lateral leg and also the dorsal surface of the foot. What do the muscles of the lateral leg do? They pull the lateral side of the foot out, or evert the foot. When you think about the tibial nerve, you should think about the tibia, which lies medially in the leg. This nerve provides innervation to the muscles of the medial and posterior leg, and also the plantar surface of the foot. What do the muscles of the medial leg do? They push the medial side of the foot down, i.e. invert the foot, as well as allow a person to plantar flex, or push their foot down like on a gas pedal. You can use the memory aids PED and TIP to help you remember the functions of each of these nerves respectively. If you look at the motor and sensory deficits for the common perineal and tibial nerves, they match the function and paths of the nerves exactly, as we've already discussed. The only thing we haven't talked about is the gait deficit that occurs with injuries to the common perineal nerve. When people walk, it's important for them to keep their foot dorsiflexed or would either drag along the ground or flap on the ground. This is often referred to as foot drop. It's a relatively common lower limb pathology. Do you know the autoimmune disease which foot drop is most often seen in? Exactly, multiple sclerosis. The last two nerves we'll look at are the superior gluteal and inferior gluteal nerves. The primary function of the superior gluteal nerve is to abduct the thigh. You can think about it also stabilizing the hip. This is indicated by the Trendelenburg sign, noted when a patient stands on the opposite foot as the nerve injury. When they do, their hip drops because the body can't shift weight onto the leg that it's standing on. Inferior gluteal nerve injuries are different altogether, as it innervates the gluteus maximus. The primary responsibility of that muscle is extension of the hip, which is not a function used explicitly by people on a day-to-day basis. Usually the injury manifests because the deficient gluteus maximus muscles cause difficulty pushing the leg downward. This makes it hard to jump, climb stairs, or even rise from a seated position.